Hope you enjoyed the long COVID and chronic fatigue forum. And today we're here to answer a few questions that have come up. I think, where shall we start? Let's start with, I think, starting off just about, someone asked a question about the Bruce-Patterson protocol. And
here are the questions.
And I think that's an interesting place to start. And I think I'll let Dr. Parpia take the lead on just how we have kind of looked at long COVID as being obviously a lot more than one thing, but a way to think about it and where Dr. Patterson's protocol fits in that. So,
okay, welcome everyone. So we've seen thousands of patients with long COVID over the past 4 or 5 years at our clinic, and they continue to come. So having seen so many of these patients, I've been able to really put a lot of thought into this, right? And I categorize them into 2 different types. And in those 2 types, there are multiple subtypes. And I want to go over the 2 different types of patients I see who have long COVID. The first type I call long COVID type 1, and they have strictly long COVID mediated issues. So strictly viral or spike protein mediated issues. They have microclots. We can test that on the labs. They have a reservoir of spike protein or virus. We can measure that on the labs. That's pretty much all they've got, okay? If they fall into this category where it's only spike protein or SARS-CoV-2 virus mediated, you give them Dr. Bruce Patterson's protocol and it works well. You can give them the Maraviroc that blocks the chemokine receptor 5 on the monocytes. It's going to bring inflammation down on the monocytes. You can give them pravastatin or atorvastatin. It's going to bring inflammation down in the blood vessels. So people who do well with this program, usually they're well within 6 weeks to 3 months, and they get to go on with their life. It goes by or goes back to normal. The patients who you give them Dr. Gordon dropped his glasses just a moment. So the patients who you give them Dr. Patterson's protocol, maybe you add on a couple other things. Maybe you give them some melatonin, some low-dose naltrexone, some curcumin, okay, and Patterson's program, and NAC, okay, they do well. Cool, that's good. That's all they've got. But the people who that doesn't work, after 6 weeks, after 3 months, it's really too long to wait if they're not getting better after 3 months on that. We know that they've got other things going on. This is what I consider subtype 2, where they've got COVID-mediated issues, the microclots, the coagulation issues, reservoirs of COVID or spike, but now they have autoimmunity. There's molecular mimicry going on. There's other chronic infections which were dormant that have now woken up, so to speak, like the herpes family of viruses. We've seen a lot of Epstein-Barr virus, cytomegalovirus, HHV6, HSV1 and 2 reactivation, a lot of tick-borne disease reactivation. People can be in chronic Lyme and tick-borne diseases and they didn't know it. So these people have all of this going on. They have a high inflammatory cytokine load, higher than what you might see with only patients who have COVID subtype 1 that I've observed. They have a high environmental toxin load. They've got a lot of microplastics. They have glyphosate that's high. They have high heavy metals. And so there's a lot more that we have to do for this subset type 2. And that's when the Dr. Patterson or other cookie cutter protocol for long COVID is just not going to work. We have to dig deep and make this very individualized.
yeah, I think that's a good overview of what makes long COVID so difficult for the conventional world, is because they're still looking at it as mostly, they were in the beginning anyway, as a only COVID-related problem. And there are lots of little things that can cause problems. So,
Eric, there's a question here for you. I'll read it. Dr. Gordon, regarding plasmapheresis, can you clarify the number of sessions needed to help someone level up? In the plasmapheresis bonus video, I believe you said it was typically 2 sessions. In other talks from you and others, I have come to expect that 6 to 8 sessions were necessary for effect. What are the factors involved?
Well, typically in the past, we use plasmapheresis for people with severe autoimmune issues, things like PANS and PANDAS. And for those, when we're just trying to treat and lower the autoimmunity, then you're going to need the 5, 7, maybe even 8 sessions, but usually 5 to 7, in order to completely remove the antibody load from the system. And at that point, we hope the system begins to reset, or we can then begin to treat things without having an immune system that's as overreactive. So so it takes 5 to 7 plasmaphereses to really get the antibodies out of the body. Because each plasmapheresis only removes about 50% of what's there. So you got to do it about 7 times to get close to nothing. And often people will need IVIG to follow up to help just continue to help the immune system quiet down. But when you do this, this is not a curative thing. Okay, that's the problem with plasmapheresis. It's got 2 things against it. 1, it's expensive, and 2, it's not going to make it all better. It's just going to change the milieu in the body and allow the system to change, your immune system to calm down a bit. And then also that allows other interventions to work without flaring an immune system that's very irritable. The 2 sessions, that's for toxin removal. Okay, and that is really important because many people, we also will drop the antibody load down a bit, which is helpful. But the 2 sessions really lowers the toxin load. Now, again, it's not enough, but very often 2 sessions within a week, and then maybe a month later, another 2 sessions, and sometimes so you can still get up to 6 of them if you do this over 3 months. But since there's a lot of things that we can do that are a lot less expensive, often 2 is enough to begin to lower the load and really get the body moving again in the right direction. Because again, we're not fixing a problem, we're just removing a big irritant, something that keeps the immune system in a hypervigilant state. And then other things we do will work a whole lot better. Obviously, 2 sessions are not going to remove all your toxins, but it's going to lower the load. And then there's always a lot of other things to do, chelation, binders, etc. That will help. And this can also give us a chance to help heal the gut, because as always, that is a really important piece.
Okay, I have someone has asked, why is it so difficult to treat heavy metals in patients with autoimmune conditions? So this is a multifolded answer. I'd say I could give an entire webinar on this. I probably will in the future. I'm going to make this a short answer in the interest of time. So when somebody isn't able to chelate very well, it's very often that they don't have enough micronutrients on board. We need minerals as our cofactors, we need B vitamins, and we need amino acids as cofactors to allow for the heavy metal detoxification process to take place. So a lot of people who have autoimmune conditions also are low in these cofactors, likely because there's an issue in the gut. We know that gut issues are also directly correlated with autoimmune issues. They can be a causative factor, multiple causative factors of autoimmune conditions. So it's very often we have to replete people of these cofactors before we begin to chelate. And there are many other reasons somebody shouldn't be chelating as well. A lot of people who have autoimmune conditions do tend to have constipation or diarrhea, that goes with the picture. So to chelate somebody when they have constipation or diarrhea, that's not the right thing to do, because we're just going to recirculate those metals. And those metals, when they recirculate, they're just going to land in other parts of the body. Some of them can cross the blood-brain barrier. So these are all good reasons why it can be particularly difficult for chelation therapy to work in people who have autoimmune conditions. That being said, heavy metals can also be a causative factor for autoimmune conditions to take place. So it needs to be done if the person has a high heavy metal load. And that requires a lot of testing in very, very specific ways, which I won't get into right now. But if you're working with somebody for chelation, you want to make sure that they're trained in chelation therapy, because there are smart ways to chelate and there are not so smart ways to chelate, which can make somebody get sicker. So, yeah.
Yeah, and I think we've had, I think, a few forums around heavy metal toxicity, and we'll have more to come, because it's an area that is so important. And I just want to, emphasize that the trace minerals, I mean, that's something that is long been neglected. And without them, people always think, the zinc and copper, which are really important, but there's a whole bunch more: molybdenum, manganese, selenium, that are cofactors for the vitamins. And without them working, your enzymes don't work well. And that is probably an underlying reason why a lot of people wind up getting ill. And it seems like a surprise to them when they get ill from the bug, the acute event. But it's usually because there's underneath been a long history of malabsorption of these trace minerals. And I said, this is something that in our coming forums, we're going to do a much deeper dive in, because I think it's kind of at the bottom of a lot of people with especially ME, CFS, and long COVID.
I think I've done a heavy metals master class on all of this. Actually, if I do, we'll dig it up and
repost it.
repost
Okay.
it.
And a very good question for MCAS. What if you can't take antihistamines or mast cell stabilizers? Well, this goes back to what Dr. Afrin, those of you who are familiar with the MCAS world, I always call Dr. Afrin is kind of the godfather of that world at the moment. He helped really teach most of us about how to think about MCAS. And one of his most important points is that avoiding the triggers to your immune system is probably the most important thing. The mast cell stabilizers and antihistamines are just ways of quieting down the body, and to give you some relief, but they don't get you better. Okay, and even avoiding the triggers isn't going to get you better, but it's definitely going to help a whole lot. And it's easier said than done, because most of us don't know what the triggers are. And that's a lot of work on that. But one big hint: if you can't tolerate the antihistamines and the mast cell stabilizers, there's a very good chance that you are sensitive to some of the constituents of those medicines. It's not the drugs, but it's the fillers and binders that are mixed with them. And if people are very sensitive, this can happen even with compounded ones, because there are people, because we often use methyl cellulose as a binder, as a filler, actually not a binder, a filler in these medicines. And methyl cellulose can come from various different plants. And so you can be taking a supplement or an antihistamine that's working for you, and then you get a new batch, and suddenly you're reacting to it. And so this requires a lot of deep detective work on your part and your physician's part, but it's the kind of work that sometimes the patient has to do themselves, because it's time consuming to go back and talk to the pharmacist and find out, what their source is of the different binders in these medicines, and especially just to cross check, if you've taken 4 or 5 antihistamines and you react to all of them, what are the ingredients in there? Because it's rarely the antihistamine itself that your body is reacting to. Um, so that's the thought process that has to happen here. So there's not an easy answer for this
I
one.
just want to jump in here. So a lot of people who can't quite take or maybe they don't want to get something compounded, right? So a lot of these medications, we can get them compounded from the compounding pharmacy where there aren't the additives, they aren't the fillers. Some people don't want to use that for some reason. They do great with peptides. Okay, so peptides are a fantastic way to treat MCAS when somebody can't handle the typical antihistamine medications. I start with tiny, tiny dosages in some patients, like toothpick dips or sprinkles of Amlexinox, for example. KPV is another mast cell stabilizer. And then we can go on and use other peptides that help to modulate the immune system. LDN can also help with MCAS using tiny, tiny dosages in this patient population. A lot of times a little goes a long ways with that.
I think that's very important. And remember, underneath MCAS is almost always some chronic irritant, and in our world, usually it is a chronic low-level infection, or a toxin. And the difficulty here is that when your body is so reactive, when your immune system is so reactive, that we always try to treat the MCAS first, and that's where we use all these antihistamines and mast cell stabilizers, and even some of the occasionally there's more aggressive treatments using some of the newer medications for initially they were for cancer therapies, but they're being used in autoimmune diseases at tiny doses to try to stabilize the immune system. But before you go there, you really want to make sure that it's not the fillers or binders that are causing the problem. So let's see for another question here.
I want to talk about ways to diagnose long COVID.
Oh,
that's
good. What is the most accurate test for long COVID spike protein? Okay.
And the question above it is also, what is the best way to diagnose long COVID? Is it lab tests in combo with clinical picture? And if budget is a consideration, what are the basic lab tests? Okay, so diagnosing long COVID by labs, it's not an easy endeavor. There are many different labs we can do, and there are many different labs I do if it's within a patient's budget. So I like to do the inflammatory cytokine panel by Radiance Labs or by InfectoLab. That looks at different inflammatory cytokines, obviously. I like to do the microclot lab by MedHelp. It helps us understand if there are microclots indeed due to long COVID affecting the vasculature. I think that's an important consideration. I like to use the InfectoLab, a SARS-CoV-2 spot. It's looking at interferon gamma and interleukin-2 to against either spike protein or the virus. That helps us understand if there actually is a load still of virus or spike protein. So that's important to know.
And this one is for people, again, those are all tests that are, $400 or $500 a piece. So the LabCorp and Quest, you can start there, okay? Because if you if you just check antibody levels to spike protein itself, because you can get the antibody for spike and also the antibody for what's called the N. It's the N protein, which now the N is only found when you actually have persistent virus, okay, or you recently had COVID. I mean, that's the problem with these two, with the LabCorp tests, is because if you just had COVID 2 months ago, they're both going to be positive probably. But if you haven't had COVID in a while, and if you check this over time, if things are working as they're supposed to, the general test for the antibody test for COVID, But the N protein, which is from the virus itself, that should come down within 2 or 3 months. And the same thing with the spike protein. I mean, one of the reasons people kept pushing the frequent immunizations for COVID was because even when we use spike to stimulate the immune system, that antibody disappears. Well, it's supposed to disappear. Now, it turns out that in some people, if you keep producing the antigen, the spike antigen, you're going to keep having the spike antibody, which is what we can measure in LabCorp. So if you haven't had COVID and your spike antibody level is still very elevated, then you have a problem with either persistent spike production from the vaccine or persistent immune response. And again, if it was from having COVID itself, you generally also see the N protein elevated as well. So those are two things that we can do that
If you're on a budget.
yeah, that are generally covered by insurance. So I think that's a very good way of doing it. Now, hopefully, the people who are doing the microclot testing, I haven't checked in with them in the last few months, but eventually they will be able to, using some fluorescent staining, to tell us whether this is a microclot that's really due to long COVID versus microclots that can be there because you've got persistent infections from other bugs.
Right, but that leads into another way that we need to diagnose long COVID, right? So the ways we just discussed are ways to understand those that are mediated by the virus itself or by spike protein. There's this other side to long COVID, which is the waking up of dormant infections that I mentioned earlier. So typically I'm running a test for tick-borne diseases. If the patient's symptoms are telling me to run that, we can tell, right? That informs the physician. Yes, we need to test for tick-borne diseases, or yes, also the herpes family viruses. We need to test the microbiome. We know that the virus and spike protein can really aggravate the microbiome. Not that we can test for the virus itself in the microbiome, but we can test for other things. We can look at the other bugs in the microbiome, ones that shouldn't be there. We can look at inflammatory factors in the microbiome. Another thing I think that's really important and overlooked is the sinuses, the sinus microbiome, because the epithelial tissues from all of our cavities can get irritated from spike protein or the virus. So there's multiple different tests that we need to do looking at the entire terrain, the entire system of the patient in front of us based on their clinical picture. So running everything that is very specific to COVID, running everything else that COVID wakes up.
Yeah. And here's another question that actually is a favorite of mine. Someone from England who writes that they've had either migraine or daily chronic headaches since spring of 2021 when he I only had a couple of weeks worth of. Anyways, basically, he's saying since COVID, okay, and he's been through a lot of different medications, also an MCAS protocol, and nothing has seemed to help. He's been to a neurologist, had a bunch of MRIs, and this goes back to my favorite thing, and we're going to actually do a whole forum about it, is structure. It's because what is often missing when people have chronic daily headaches or frequent migraines, tinnitus, lots of things, and that feeling of pressure in your head. Well, this has to drain. And when this and this is tight, it doesn't drain well. And, we just take for granted, especially in the chest, that, because we don't really feel what's happening deep inside there. But you've got a lot of fascia, which is connective tissue that surrounds all your organs and all your muscles, and everything in the body is connected and wrapped in fascia, which is that kind of like, if you ever look at a chicken, like a chicken breast, that thin layer of is fascia that surrounds the muscle. Okay. But this actually has elastic tissue in it as well. So it can tighten up and it can get scarred. And when it does, it restricts the ease of motion of the organs, but also on the quiet level, it restricts the ease of drainage, and it tightens up the veins, lymphatics. And so getting this worked on can be really helpful. Now, in the chest, the neck, and also looking at the structure. I mean, you've heard us talk about cranial cervical instability, or if you haven't, you should listen to that. And that is an extreme case where the ligaments that and the tendons that kind of hold our neck, our head on our neck, and just basically connect all the bones in the body. Those can sometimes get lax or be lax. I think all of you know, we've talked also a lot about hypermobility, and a lot of people have low levels of hypermobility that not a problem, just means you're really good at a yoga class, you look really good. But when you get chronic inflammation from an infection, those tendons sometimes and ligaments sometimes get even more lax. And then your muscles around that area tighten up to keep you stable. But that laxity allows abnormal pressures in different parts of the system, especially in the brainstem and in that first few cervical vertebrae. And that can cause muscle tension and headaches. So you've got poor drainage because of the muscle tension. And when you have either too much fluid in your brain, this CSF or cerebral spinal fluid, or too little, you get headaches. So again, muscle tension causes headaches, unequal cerebral spinal fluid levels causes headaches, and poor drainage has a lot of it. So what do you do about this? Well, a good osteopath is a good place to start. Some of the upper cervical chiropractors, such as Nuka or Atlas Orthogonal, these are non-force techniques. They're not jerking your neck. You don't have to worry. Bad things won't happen. And they can sometimes help open that up. Recently, we had a webinar with Deanna Hansen about block therapy, and this is using pressure for 3 minutes or so on different points, which she has lots of videos. A lot of them are free, and the whole program is very inexpensive anyway, but you can do most of it on your own. Open up these tissues, and yeah.
Okay, I want to jump in for a sec because we're seeing these issues much more commonly now in the past 4 or 5 years since this, post-pandemic. We saw it a little bit beforehand in our patients who had chronic tick-borne diseases, but this is becoming a daily thing that we're seeing in patients. And I think what Dr. Gordon is saying is super important. And there are other things I'm thinking about. Microclots, right? When there are microclots in multiple different areas of the body, that's going to slow down our drainage. Okay? And if you had an issue that was not much of a big deal in the past, in fact, you barely noticed it, but now you have perpetual inflammation. Maybe you've got COVID reservoirs or spike protein reservoirs that are continuing to cause your immune system to create an inflammatory cytokine cascade that doesn't stop. Now we have inflammatory cytokines that they stay in those areas where there was a structural integrity issue that wasn't a big deal in the past, and now it is. So working with all the things that Dr. Gordon was saying is important, the block therapy, working with somebody who's going to do a very slow, gentle manipulation on your neck, no high velocity at all. You want to make sure to tell them not to do that. But it's also important to consider what's happening in the sinuses, because the sinuses you got excited about the sinuses have a connection to the brain through nerves, through blood vessels. And I call that the forgotten microbiome, actually. So the spike protein can irritate the epithelium in the sinuses. It can leave us open to other chronic colonizations in the sinuses. I often see funguses, bacteria that don't belong there, or bacteria that should be in the gut, in the sinuses. When we treat the sinuses, when we do what Dr. Gordon was talking about, that structure piece that is so important, when we work on dissolving, so to speak, those microclots when we work on all the other infections, the migraines, they do go away.
Right. And I do want to emphasize craniosacral, for the head, neck, and the rest of the body could be really important because, we know, I mean, a lot of the treatments for migraines are involving nerves such as the sphenopalatine ganglion, the trigeminal ganglion. These are nerve concentrations, and they're right kind of they're not really in the brain, but they're right underneath. And the tension from your head and neck and your jaw can really keep this going. And
inflammatory cytokines can travel from the sinuses to the brain via the olfactory nerve and via the trigeminal nerve in your face and its lymphatics. So literally the inflammation can cross the blood-brain barrier. It can then trigger the microglia to release more inflammatory cytokines. So it's really a vicious circle. And
and again, so just don't forget your head, you have structure here, and it causes headaches. It is, I mean, like underneath so many people's headaches, it's this imbalanced blood flow. Okay. And that is affected in many, many people by the muscle tension in the face and neck, as well as the rest of the body. That's why I say it's good to work on your head and neck, but don't forget, because even what's happening in your feet, it's all connected. It can cause headaches, and that's what's so difficult in our world, because doctors have just don't pay attention to this, and we divided the world into chiropractors and a few osteopaths, and then people who just want to give you medicine. And again, the medicine is great when you have severe pain. I'm not saying not to take it, but it doesn't get you better. We have to look underneath. So lots of other very good questions here.
This one over here.
Okay, I don't want to overdo the plasmapheresis world, but somebody asked a good question. Common reactions, the risks and common reactions of plasmapheresis. So the nice part is medically, the risks of plasmapheresis are fairly small. I mean, they're really very small compared to most things we do, because you're not putting anything in. There's you get a needle in one arm, or hopefully a catheter in one arm and one in the other, and the blood gets pumped out through the machine and then back in, and it's all one sterile circuit, so not much can happen. There are some, because of what we use to prevent blood clotting, magnesium and calcium, especially calcium, can drop, but that's replaced usually along the way. People with very low blood pressure can need a little assistance. I mean, it's more fluids to keep the pressure going. So again, you're moving a lot of toxins, so you can feel kind of, I mean, the first time people do plasmapheresis, or something the first or second time, they can feel kind of icky afterwards, depending on how much of a toxin load their body is moving. Because when you move toxins, you redistribute the ones that you haven't moved, and they can make you feel not so good. But that's usually transitory. Almost always it is transitory. If you have underlying infections, I mean, we see this a lot with Bartonella. Anytime we use more than 2 plasmaphereses with Bartonella, we want to be treating either with antibiotics at the same time, or using IVIG, low doses, just enough to keep your immune system working well, because you are removing a lot of antibodies, which isn't really a problem for day-to-day issues for that few days until you build up new ones. But if you have active bug and those antibodies were really important at keeping that quiet, it can be, you can really have a flare of the infection. So that's the most important thing. Everything else is we cover we're watching pretty well. So it's very safe. The main problem with plasmapheresis is that, unfortunately, at this point, because of the expense, I mean, the machines are about $120,000 to begin with, and how long it takes, and the disposables, it's expensive, and so it's not a first line treatment. Okay, please understand that this is not something that you do in the beginning of whatever's going on with you, unless it's severe autoimmune or mushroom poisoning, which sometimes it works for. But no, this is not a first line therapy.
Eric,
Okay.
someone else is asking if plasmapheresis is the same as ozone. It's absolutely not the same. I'm gonna have you answer that.
Well, yeah, I mean, because there's something called EBU that someone else
Someone
asked
else
about.
talking
Yeah,
about EBU.
EBU, which is using a similar system, but much simpler system where the blood is removed and they're using a dialysis filter, which and by the way, dialysis and plasmapheresis, though they share the same concept, you remove the blood and you're filtering it, totally different, filtering totally different things and different equipment. But when they do EBU, they use a dialysis filter, and there's two different types of EBU out there. One I think is much better than the other. One of them merely uses the dialysis filter to supply low-level ozone to the blood, and the other one actually filters the blood through the dialysis filter as well as giving low levels, but it's very low. We call gamma, which is just a measurement of ozone, milligrams per milliliter, but they call it gamma. But it's very low level, but it's to, a few thousand cc's of your blood, sometimes all of your blood. And so it's effective, and it does really help people with infections, especially with viral infections. How much toxins it removes, people haven't measured as far as I know yet. And I mean, I said, in the office, we don't use EBU. And it's nothing against it. It's just that, how many things can we do at once? And I'm been very happy with the effects of 10 pass ozone. However, I have many friends who are doctors who do it, and they have good results, I think, with infections, and in some people with long COVID. Again, don't have numbers, and that is the big problem for all of us. We don't have numbers. We have a lot of anecdote.
I've seen too many people who've come to me as a patient, and they did say 7 or 10 pass ozones, and it helped some, but not all. It's because treatments need to be they need to address multiple spectrums. They need to be multiple layered. If just one thing is going to treat you, then I'll be very surprised, especially if you're my patient. Okay, so I can't say that ozone is going to treat long COVID or ozone itself. Someone asks, is EBU going to get rid of spike protein?
No, it doesn't, as far as I know, filter spike, because again, most of the spike is on the we believe is either in the gut or in the endovascular, I mean, on the lining of the blood vessels. It's not so much floating around in the blood. What we're generally measuring in the blood when we measure is antibodies to spike protein and T cell response to spike protein. And that's another thing just to mention is the InfectoLab test that we spoke about earlier is looking at your T cells response. And what's interesting, why that's important, is because the T cell response to an infection is only present when your body's actively fighting the infection, and it goes away within a few months. These T cells, it's not like antibodies are supposed to be hanging around a long time. How long they depends on the antigen, meaning depending on if it's something like Epstein-Barr, you can have the antibodies for the rest of your life. Something like the common cold and COVID, those antibodies go away in a few months. So it's very variable. But when you see a T cell response to the antigen, and that's how they test it on the InfectoLab, when those T cells that are responding are still in the bloodstream, your body is still noticing that bug. That bug is still there.
Yeah, that's why that's my favorite test for understanding if you have a reservoir of the virus or spike protein still. If you have a reservoir in your body and that's based off of that test, then we're going to be treating that. We're going to be treating it differently than if that test came back negative, but all you have is microclots. I want to answer Yasmin Husanali's question. Her two teens have made a lot of progress with long COVID, Lyme, EBV, COVID, but still have CFS and in the chronic fatigue syndrome, particularly really excessive sleep. They're sleeping 14 to 15 hours every 24 hours for the past 2 years. Any thoughts, not stimulants? So I'd want to understand, is there still an active microbial count of something there? I would want to do the infectolab test, not just antibody tests. We can do that infectolab test for multiple different microbes. I would run the advanced viral complete test for that. That would really help me know, is Epstein-Barr virus or cytomegalovirus or one of the other viruses tested on that test? Is that what's contributing to this problem? I would want to run a nagalase test. There are thousands of viruses. We can't test for all of them. But you think it's gone?
Yeah, the lab
It's gone. No.
Yeah.
No.
Yeah, it's one of my favorite labs that has been around for
I thought their methylation panel
no. The lab, unless we send it to Europe. This is a great lab, Health Diagnostics, that was with us for almost 40 years, but unfortunately, they had a reorganization and just a month or two, a few months ago, and they haven't come back that I'm aware of.
I'm very disappointed.
But anyway.
Okay. Anyways, if we can find a way to test nagalase, maybe some lab testing companies listening to us right now, I want to be able to test nagalase. Again, that will help me understand if there is a viral issue beyond the, say, 10 viruses I can test for that could be a contributing factor here. So when somebody has chronic fatigue syndrome, this is the most difficult part to treat of long COVID or chronic tick-borne diseases. I'm thinking, are there any active bugs still? I'm going to test through and through, in and out. I'm not going to leave a stone unturned for that. I'm wondering about the hormones. Even though they're teenagers, a lot of people forget to test the sex hormones of teenagers. Well, the endocrine system can be very disrupted by COVID and by tick-borne diseases. Maybe they need a little bit of help there. Maybe they still have a microbiome issue and there's a gut-brain axis issue going on. Maybe it is now time to put them in the mitochondrial and cellular membrane repair shop. I consider there to be sort of two parts of treatment. One part of treatment is when we're treating chronic infections, when we're working on the drainage, on the structural integrity piece, when we're doing active detoxification based on the toxins that we see in this patient. Is it metals? Is it glyphosate? Is it microplastics? Whatever it is. But we're in active treatment mode, killing, detoxing, immune modulation. Once that is complete, we then work on cellular repair and mitochondrial repair. It's very often that people still remain fatigued until the second portion of treatment is complete. Now, I'm not working on mitochondrial repair while I'm in the active treatment phase because our mitochondria are creating oxidative stress. They are creating inflammatory signals. And when we start to feed the mitochondria when they're in that state, we're only triggering them to create more of that inflammation and oxidative stress. So it's important that the mitochondrial treatment is done after we're in the active phase of treatment and detox.
Yeah. So again, as Dr. Parpia said, it really is, once you've, if you're kind of in this plateau place, it really is time to start working on rebuilding. And that's, that's where the peptides, the bioregulators, and the mitochondrial support really come in.
I want to say something about the peptides. I'm glad you brought that up. So I use peptides often during the active phase of treating chronic infections and modulating the immune system. At this point, they're Band-Aids. They're amazing Band-Aids, and I need those Band-Aids to modulate the immune system. I have nothing else that's going to modulate the immune system as well as peptides will. Once we are in that repair phase, I have seen that the peptides actually work to reprogram our systems to give permanent treatment. So people aren't dependent on treatment forever.
Yeah. And, and one thing we're going to be talking about in our average, feel like a TV show here, advertising for the future, but, we're on the next forum, and we doing on cutting edge therapies. We're going to be talking a lot about exosomes and stem cells, which again, pricey, so and not something everyone needs. But when everything metabolically looks like it should be working, but it's still not, many, and especially in young people have an amazing response to exosomes and stem cells, often just exosomes because they're which just are anti-inflammatory information. It just lets the body, oh, it's like the peptides. I mean, you start with the peptides and the bioregulators, but if you're still stuck, they'll often just give the information. The system wakes up because that is the amazing thing about young people. Okay, is they can be really, really sick, but they get better really, really fast. That is when you finally get there. It's just amazingly different. You know, as we age, the ability to repair just goes down. There's so many systems are now offline or just operating at 30 or 40%. And you know, when you're a teenager, they're still operating. You know, once you clear out the gunk, they go back to operating at 100%. And you know, like my great example, kids fall down the stairs all the time. They do it for fun. You know, have a 6-year-old fall down the stairs. Not only isn't it fun, it can be a life-changing event, in the negative. So, you know, young people, they will get better. I mean, they just need the right push.
Oh, the bioregulators are amazing to help people system by system. I also don't have anything in my pocket besides bioregulators that target DNA in different systems of the body. So that can also help with fatigue. Maybe the pineal peptide could help with that. Eric, I want you to answer this question. There's a lot on apheresis and I'm putting them on you. So
Actually. No,
here, I'll read
okay,
the
well,
question.
yeah, I'm reading just to know what I was getting
Okay,
into.
I'm going to read it. So for me, a
Okay.
chronic ME/CFS patient, I had 2 apheresis sessions. It was very, very tiring. Actually, I got COVID after that, I guess because the patient next to me was so ill with long COVID that I contracted COVID. Is it normal for the head to heat up with apheresis? I mean, depends how hot it got.
Shouldn't.
It shouldn't.
Okay.
Okay, mine did, and my eyes became red and small veins in the eyes popped. Is this normal? Typically, no. I would give you the blood vessel bioregulator, though. I'm not sure how I should feel with my apheresis sessions. It did not continue them up till now.
Well, yeah, no, those are not symptoms that I would expect from apheresis. I mean, we've managed enough of them now that no, I mean, again, everybody is their own being. So I always hate to say, oh, that's impossible. It obviously happened to you, but I don't know why. It could be it could be because I said we do replace calcium, magnesium, and it might have been if the amount or the speed of the magnesium. I mean, if you give people magnesium fast, your head and your chest and often the groin will feel hot because it'll increase local blood
It's
flow.
probably that. Or you have a microclot issue,
Well, but even that
you know?
shouldn't do that. It really shouldn't.
To that level.
It's so this is, I said, this is not a typical response to apheresis because I said in apheresis we're removing things and but again we are putting back minerals. So perhaps the speed was too fast because that could cause those problems.
Okay, someone's talking about heavy metals. When chelating is redistribution in actuality, it absolutely is in actuality if chelation isn't done correctly. So it goes back to when I spoke earlier about the cofactors for our detoxification pathways, B vitamins, microminerals, amino acids. When we don't have enough of those on board and we're using substances to chelate that are going to pull metals from outside of the cells, We then pull the metals outside of the cells. If we're not, if we don't have enough cofactors on board, if we're not supporting the organs of elimination, the liver, the kidneys, the lymph, the gut, that can also cause redistribution. If somebody has constipation as an issue, that can cause redistribution. So chelation therapy isn't something that should be done casually. It's medical. It's a medical detox, and so you need to have somebody who knows how to assess if chelation therapy is the right thing for you or not, or if it's the right thing at the right time, and to prevent redistribution.
Yeah, and just understand redistribution is just the chemistry of the system. Anytime chemicals are in the body at proportionate to how much is there and so anytime they're in different compartments of the body, like in the blood, in the tissues, in the plasma, in the lymph, and they're actually proportions, and that's just how chemistry works. And when you take something out of one compartment, it's going to redistribute whatever else is, if it's sitting deeper in the cell, because we only get out what's on the cell surface, then more comes to the cell surface, and sometimes then more gets off into the system. That's why using the chelators and using binders along with the chelators and trying to be
and getting a mineral IV after, at least 2 days to 1 week after your chelation IV, you've got to replete the minerals, because when we chelate, minerals get pulled out as well.
Yeah, and that's one of the things that we often do now is chelate people after 3 days or so, 3 to 4 days after apheresis, because your body has redistributed a lot, and it's a good time to get more out easily. And that's a whole lot cheaper than doing another apheresis.
The person's also asking, can it be the same with non-metal toxins like organophosphates, phosphates? Yes, it all has to, chelation and all detoxification, when it's a cellular detox, it has to be done very carefully to prevent the redistribution from happening.
Okay. And this is a great question. Why are you short of breath at rest? And what do you do to help people with it? Well, lots of different reasons, but one of the simplest that happens is that as we are, just living in this modern world, people tend to breathe shallow, okay? And when your body gets more and more oxygen in the system from shallow breath, you actually wind up feeling, you have to retrain your body to tolerate carbon dioxide. And the good thing about doing that is when you tolerate more carbon dioxide, you actually get more blood flow and more oxygen delivery to tissues. So there's one simple thing that's been around for a long time is buteyko breathing, but there's lots of different systems. I mean, almost any breathing exercise that gets you to, usually it's best your nose, first of all. Breathe through your nose. If you breathe through your mouth, you're going to be, your diaphragm's not going to work well. The whole body's not going to work well. Also, if
someone is a mouth breather, I'm wondering what's going on in their sinuses, and I want to treat their sinuses.
Good point. But mouth breathing is very, very common and really bad for you. And again, posture, the head forward posture, there's just not enough room to get air in there comfortably. But the problem is how low your carbon dioxide is in your bloodstream, the bicarbonate. And when that's low, you tend to wind up continuing to feel like you need to breathe more, even at rest. Now, we do see, things like babesia, we call air hunger, and it may be part of the reason that people feel this air hunger or just, short of breath all the time is because they have excessive ATP on the cell surface of their cells. And I don't know if I've done a CDR talk in a long time, and hopefully we'll have got to get Dr. Navio on to do one of these days. But the basic concept is that the first danger signal your body has is when your mitochondria stick ATP on the surface of the cell instead of using it inside the cell for energy purposes. You use it as a signaling molecule, and it's a signal at low levels. It just signals pay attention. okay, because you get so much input all day, all the time, your brain has to know when to pay attention. And one of the signals the body gives to pay attention to something is a little more ATP on the cell surface. But if it's too much, it's a danger signal. And we do know from experiments they did in the 90s, they were trying to use intravenous ATP for cancer patients who were wasting away to see if it would increase their energy. And one of the major side effects of it in people and animal models is air hunger, short, feeling like you can't get enough breath. So one of our ideas is that the persistent inflammation can engender the air hunger. But still, there's a really good book whose author I forget. I think it's called Breathe or Breath that has a lot of different ways, different, because this is, I mean, the science of breath has been worked out in almost every culture. So whether it's, Taoism, Chinese medicine,
Hinduism,
Ayurvedic, it's everybody's got, I mean, all ancient traditions, Native Americans, everybody's got breath exercises, and they all will help that feeling of shortness of breath, despite what's driving it. Okay.
We have a couple more minutes left, and I just want to clear up a little bit of confusion. There's a question here. You mentioned even compounding pharmacies can give drugs that still cause reactivities. One would think they're set up to prevent that. Why would that not be? Well, they are set up to prevent that. So when something is coming from the compounding pharmacy, it doesn't have the additives or the colors or the fillers. Our patient,
if you ask for that, because
that's true. Sometimes they have that stuff, but you have to ask for that. It's very often that our patients are still not tolerant of the medications, even when they're coming from the compounding pharmacy. Low-dose naltrexone is a really good example of that. Typically, the starting dosage is 1.5 milligrams for 3 weeks. Then you go to 3 milligrams for 3 weeks, then 4.5 milligrams for a starting dosage. Since this pandemic, I've noticed that a lot of people can only start at 0.2 milligrams. Now that comes from the compounding pharmacy. 0.2 milligrams, that's a tiny, tiny dosage. That's all the patient themselves can tolerate at this time. It overwhelms their system. So it's not about the purity of the compounding pharmacy, it's about the person and how they're responding. So normally these patients do really well with even more simple molecules like the bioregulators and tiny dosages of peptides. And then we see their MCAS starting to improve. And then we can bring on the medications from the compounding pharmacy, which are indeed pure.
Oh, but let me just, but the point is you can still react, okay? Because the problem is that you can react to almost anything.
Even water.
Yeah, so the compounding, as I said before, they try to use the most simple, pure products, but but they still have to be made from something. And so, like I said, the methyl cellulose, I mean, they have other ones, but that's a great example because that's used as the standard in compounding pharmacies to fill the capsule because what you get might be too tiny, and they have to measure it, so they mix it in with methyl cellulose. But that can come from different plants, and if you're allergic to the source plant, it could be a problem for you. I mean, it's just like sometimes they'll use olive oil. Well, if you have one of those rare people, some people react to some of the terpenes in olive oil. I mean, so it's not a question that the compounding pharmacy is doing anything bad. It's just that you're sensitive to what most people aren't. And so
and a good workaround is starting with low dose of peptides. I've noticed we have one more, well, we don't have one more minute, but I'm going to stay on a little bit longer if you guys don't mind, because it just ties into one last question. Not sure to what extent you use herbs in your practice. We use herbs a lot in our practice. All of the doctors do. Is there any truth that those with MCAS typically react to whole herbs? Yes, they do. And the reason I'm answering this question right now is because it ties into what we were speaking to earlier. There are many different chemical constituents of herbs, and a lot of patients are sensitive to having multiple different constituents being thrown at them at the same time. And so again, back to the peptides and bioregulators, they're much more simple molecules. chains of amino acids are 40 or less, and people can tolerate those better. People can tolerate the medications better at low dosages when they come from the compounding pharmacy, and we know they're not using something the patient is already allergic to.
And this is just to emphasize here. Yeah, the reason we love botanicals is because they have so many constituents in them that we don't know what they all are, but plants and us, we're kind of got the same, the same vibrations, if you will, or maybe, and we need those vibrations, the information. The reason we have so much trouble treating people is because people have trillions of cells and trillions of microbes, and we're at that place where random is very important, and it doesn't. Our brains like 1 + 1 is 2, or A caused B. But in the body, it doesn't work that way unless you're at death's door, then A causes B. But when you're alive and functioning and walking around, things aren't that clear cut. But when you get really sensitized, all those wonderful symphony of information that's in an herb, well, there might just be a few notes in there that your body doesn't like. And that's why we tend to avoid the herbs
in the beginning.
With
then
people.
We go on to them.
Yeah, but in the people with MCAS, it's not a good place to start usually. I mean, every once in a while, but again, some of the herbal remedies do work even with MCAS.
People do well with perilla and quail egg early on. The people who are sensitive to, say, quercetin, and there's a lot of people who are in the beginning. Those are ones which I found.
Yeah, right. But I think, but they're talking about more complex botanical compounds using the whole herb. The whole plant is problematic in people with MCAS, and it just is until we get that quieted down. But it's not that they're bad; it's just in that person. So, we
are out of time. We'll wrap up. Thank you for joining us.
Yeah, it's really fun. I mean,
we always
and I want to thank you. Really great questions.
Really, so thoughtful.
Always make us think a little bit more. So thank you.
Until next time.